Welcome to Let's Talk Micro.
Hello, my dear audience, and welcome to another episode of Let's Talk Micro. Let me start by saying that it is so good to be back recording a new episode. I am so happy. So, thank you so much for listening. As I had said before when I released the episode of the microbiocide for Neisseria gonorrhea, that I was going to be having some rough weeks. As you know, I am going through my master's degree. I'll be done in December. And one requirement for graduation for this particular master's degree is that you have to take it's a 1 credit class where you do like a 15-page paper with over 50 references about a topic, but there's a specific format, and it was very time consuming. But at the same time, so rewarding because I learned so much doing the research. But I have to say that it really took a lot of time. So that's why in the past 4 weeks, you had 3 reruns of episodes and 1 week where an episode wasn't published. But I'm happy to say that I turned in my paper, I passed, so all I have to do is get through this last class that I'm taking, and I will have a master's degree in December, so what a great present for the holidays, right? Having said that, even though 3 of the episodes were reruns, it is great content, so if you didn't get a chance to check them out, please go ahead and do so. 2 of them one was for biochemicals, catalase and coagulase. The other one was about media. And the 3rd episode was about veterinary microbiology with Kelly Maddock and Sarah Geffro. So this is a good episode where you can learn something else that you can do as a medical laboratory scientist, which is work in veterinary medicine. So overall, great episodes. And if you haven't checked out the one about the microbiocide for Neisseria gonorrhea, I definitely invite you to go ahead and do so. Great content. Well, once again, happy to be back. And as you know, Let's Talk Micro is available on Apple Podcasts, Spotify, Amazon Music, Goodpods, wherever you listen to podcasts, you can find Let's Talk Micro. So please go ahead and subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. Thank you so much for the support. And as you know, the Let's Talk Micro podcast does not have any sponsors, so if you want to support the podcast in any way, you can do so via a Venmo link or via Buy Me a Coffee, Ko-Fi, both links available on the show notes. And of course, if you're looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more, and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. And of course, those are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. Okay, I am not gonna take much more of your time, but I just want to let you know about today's episode. It's the next episode on the AMR series with Andrea. So if you have been waiting for the next episode, here it is. If this is your first time tuning into the Let's Talk Micro podcast, there's a sub-series within the podcast which is about antibiotics, and the goal is to really break down antimicrobials and go over things like mechanism of action, organisms that the antibiotic has activity against. We talk about intrinsic resistance. We reference the CLSI. And in this series, I am always joined by fellow microbiologist, Dr. Andrea, and we always bring a guest. And by now we have done beta-lactams, we have done fluoroquinolones, aminoglycosides, tetracyclines, polymyxins. And today's episode is about glycopeptides. And of course, those of you that work in the lab, you're familiar with one drug that is part of this group of glycopeptides, which is vancomycin. And those of you that work in the lab and you see enterococcus, you see staph, and you're checking that susceptibility profile and checking that vancomycin, right? And of course, with this type of episodes, we always break things down, as I said before. And one thing of interest was that maybe those of you that work in the lab, maybe you have noticed that, let's say when you test, Staph aureus, for example, you typically see the MIC of vancomycin about 0.5. And, with CLSI guidelines, the highest it can go is 2 for it to be considered susceptible. And maybe you have noticed that maybe you get that MIC at 1 or maybe 2, and then you get a request. Typically in the lab, you might use, let's say, Vitek to test, for vancomycin Staph aureus. And then you get a request to use another method like an e-test. So this is addressed in the podcast, and the reason is given as to what happens when the MIC of vancomycin goes to a certain level. So all in all, great episode, great information, great guest. So let's go ahead and listen to it. Hello, dear listeners. The AMR series is back. I know if this is the segment that you love and you've been waiting for it, well, wait no more. The next episode is here. I told you before that I was going to work on some episodes, so with some logistics. But here we are. Very happy to do it. And of course, right, there's no AMR sub series with Andrea Princey, so she's here with me today. Andrea, how are you?
Hello, I am doing very well. I've missed you. It's been, gosh, I think a few months maybe. Lots going on.
Yeah, I think I saw you doing microbe in Atlanta, and so as I told the listeners, this is my last semester of my master's, so definitely very busy, and I told them that they might not get the episodes with the frequency that I'm known for giving it to them. So, but of course, to do a good episode, you need to spend some time on it. So they understand there's always many episodes to choose from, so you can always go back in the catalog or catch up. So they understand, so I'm very grateful for that. But definitely very busy doing a lot of stuff at once. So I can't wait till the holidays.
Oh my God, but here you are doing another podcast episode nonetheless. You see how dedicated you are. I love it.
Indeed, yeah. And actually, this is one of the things that with all that I have going on, this relaxes me. So I wish that I could do this and maybe put some of the other things, aside, but unfortunately I can't. So I have to wait on this. But this is like, yeah, I definitely enjoy doing this, and it relaxes me. So I wish I could do more of it, but I can't for the time being.
If you're listening and you want to sponsor Luis's podcast so we can do this full time, get in here. Give him a call.
Definitely, please. So let's talk micro at outlook.com, and I have another one which is let's talk micro at gmail.com. Of course, since we've been doing the AMR series, we typically bring a guest, and there's always, great people. So, we have great conversations, and I learn so much. And in this episode, it's not an exception. So we have a guest with us. So, Andrea, you want to go ahead and introduce him?
Yes, as always, I feel very fortunate to bring wonderful colleagues of mine as guests on this podcast. Very lucky to have so many to choose from. I feel very fortunate. So today we have Nikunj Vyas, and Nikunj received his doctorate of pharmacy from St. John's University in 2012. He completed his pharmacy practice residency at Atlantic Health System in Morristown, New Jersey, followed by an infectious diseases pharmacy residency at West Virginia University Healthcare in Morgantown, West Virginia. He serves currently as a medical science liaison for BMRU. He just recently joined us, which we're really, really excited about. We're so lucky to have him. His focus is on rapid diagnostics and infectious diseases. Previously, he served as the advanced clinical pharmacy specialist, specializing in infectious diseases and antimicrobial stewardship at a large academic medical center. He also serves as an adjunct faculty for Thomas Jefferson University's physician assistant program. And his areas of interest include gram-negative resistance, antimicrobial and diagnostic stewardship, as well as anti-infective pharmacotherapy. And I'm going to add podcasting to the list because now here he is. So, Nikunj, it's so good to have you. Thank you for being here today.
Thank you for the introduction and the invite. Super excited to be part of this podcast. Hopefully, I can shed some light on some things that a pharmacist can potentially bring to this podcast.
Definitely. And, once again, welcome to Let's Talk Micro, and thank you for taking the time to being here. I really appreciate it. Okay. So I didn't say it in the introduction, but today we are talking about glycopeptides. So let's go ahead as we always, start with this type of episode. We typically, start with a general overview. So, Nikunj, can you go ahead and give us a general description? And if you have any historical facts, we definitely love them.
Yeah, so glycopeptides, they're one of my favorite antibiotic classes. And if you work in a hospital setting, it would be almost impossible for you to not come across these medications because they're such a workhorse on a day-to-day basis for our patients. So they're an antibiotics. I love med chem, which most people are not huge fans of. But when you think about antibiotics, it's kind of important to learn about the med chem aspect of it. So the cool thing about glycopeptides is that they're cell wall agents essentially, but they work differently than the other cell wall agents that you may have come across, like beta lactams, where these are like a heptapeptide cores that are glycosylated. What ends up happening is they have these lipophilic fatty chains that kind of make it a unique molecule. And And what is unique about them is that they have very specific niche therapy in place. And we'll talk a little bit more about spectral activity later. But essentially, so story goes back where in 1957, Dr. Cornfield was an organic chemist, and he was with Eli Lilly. He was in the deep jungles in Borneo, and they found a fungus that was named Streptomyces orientalis. It was in the soil samples from the jungle where they were at. And what they ended up when they brought the fungus back into the lab, and when they isolated the species, and it yielded in broth fermentation a compound that was actually very, very effective against Staphylococci species. So they thought they had something there. So then they labeled it, they gave it a number because they didn't really know what to call it at the time. So they gave it a number. It was like 05865 product. And what they ended up doing further is testing it against specific bacteria. And what they found when they tested it against Staphylococci, especially, was that all the Staphylococci just quote unquote vanquished. And that's why they came up with the name vancomycin, which is the most common glycopeptide that you're going to come across. The original product was actually what's unique about this is it's like a Jeopardy question. This comes up all the time, where the original name of the first glycopeptide ever found was vancomycin, and the other name that it's known for is Mississippi mud. And the reason for that is because when the first molecule was introduced, it had a considerable amount, about 70% of impurities, where it gave it a brown color. But it was effective, so people just started calling it Mississippi mud. And then luckily they cleaned it up, so now it's like it's not a Mississippi mud anymore. But that's a trivia question in the ID world that commonly comes up. But the other cool part about glycopeptides is basically it was, like I mentioned, 1950s and 60s is when we actually came across this molecule, but it was actually not used commonly up until the 80s because a lot of our staph species were relatively sensitive to our beta-lactams and other antibiotics. So we didn't really need to use these antibiotic or the vancomycin specifically because it was one of its kind at the time. But until 1980s, where we started coming across these resistant staph species, and that's where the use picked up quite a bit. When I think of glycopeptide, I think of vancomycin. But essentially, it's the cell wall agent that works very differently than beta-lactams, though, and it has a very unique spectrum activity and mechanism of action.
I just learned so many things. Like the vanquish thing, I had no idea.
Yeah, it's kind of cool, right? You think about names of the drug.
Yeah, there are like four, you're right. There's like four trivia points here on this list that I'm putting in my pocket for trivia night.
I mean, Vanco is a big hit when it comes to like history because you think about antibiotics, right? So antibiotics come out, they're used, they're good drugs. 5-7 years later, resistance comes into the picture. And vancomycin's been around since the 50s, 60s, and in practice since the 80s. To this day, it is our workhorse. It is our first line therapy for MRSA infections. And that's why it's a really, really effective drug.
Yeah, definitely that was a great, trivia and that would look pretty cool in a report. That was the case, right? Like some Mississippi mud, Enterococcus faecalis, Mississippi mud resistant Enterococcus faecalis. Wow. Definitely very cool to learn. And of course, those of you in the audience, if you're medical lab scientists, you're definitely familiar with vancomycin, right? We're looking at those reports and we have the Enterococcus and we're looking, right, checking, and we'll talk more about resistance and things like that. And definitely when we're looking at our staph. So you're definitely familiar with it. So of course you kind of touched a little bit on it, and I want to ask about the mechanism of action. So we did an episode before about beta-lactams, which mechanism of action is, it's cell wall inhibition of the cell wall synthesis. And this one does this, but a little bit different, right? So when we think about beta-lactams and, resembling like the diala, which I'm going to ask about, and then inhibits that cross-linking. So how does it work with vancomycin?
Yeah, it's kind of unique. So, as you know, cell wall is in bacteria because it is very rigid layers, that layer that keeps all the other things, all the other parts of the cell intact. So the easiest way to kill a bacteria, remember, I'm using the word kill very specifically because, there's cytal activity that we usually go with when it comes to cell wall agents, is to denature that cell wall. So the easiest way you target a bacterial death is to denature that cell wall. And you mentioned earlier beta-lactams. They do a little bit differently, where they work on the transpeptidase enzyme, which is an enzyme that is involved with cross-linking. But what Vanco does is usually cell wall cross-linking between the different peptidoglycan layers is with these amino acids that are alanine and alanine. So the two peptidoglycan layers, like imagine if you have like these two pillars that are being linked together to make a nice rigid wall. The linking between these two pillars is happening with these two amino acids that are alanine and alanine, which are towards the end of the chain of amino acids. In order for the cell structure to stay rigid, these cross-linkings have to take place. So what vancomycin does is a big molecule, has a lot of hydrogen bonds, and it binds to these alanine and alanine component of a peptidoglycan. So what it ends up doing is now you have one peptidoglycan layer that has these two amino acids at the bottom that are bound by this drug. So now it cannot cross-link with the other pillar. So, you have a pillar that is binding with the other pillar, but if you surround that one pillar with a big balloon, for example, it can't bind to the other one. And now your cell wall just becomes unstable because your cross-linking is something that you inhibited. And anytime you make your cell wall unstable, it denatures or denatures the cell wall. Basically, the cell cannot survive. And that's how the cell death takes place. So very different. Now, in order for vancomycin to do this, it has to be a large molecule. So vanco is a big molecule that has to get to this area and bind to it. But in order for it to do that, it has to get inside the cell to the cell wall. And gram negatives, we'll talk a little bit more about this later, but it's important in the beta and the mechanism of action standpoint. Gram negatives have this outer layer called lipopolysaccharide, which has porin channels. Vanco is too big where it can't get through these porin channels. That's why you will almost never see vancomycin used for gram negatives because it cannot actually get to the site of action on its own. But it's a unique mechanism of action because it is a cell wall agent at the end of the day. It's just that it is very different than how beta-lactams work. Hopefully that was not too much pharmacology where it was easy to understand.
It was great. Super visual. I loved it.
Yeah, definitely same here. And I love how you said, because yeah, we definitely we hear and then we know, oh yeah, so vancomycin doesn't work with gram negative rods, and kind of understanding. I definitely heard before like it's just too big, and you put it into more of a context. So thank you for that.
Yeah, of course. Yeah, actually, if you look at research that are in vitro research that comes out of Europe, especially, if you can facilitate vancomycin in gram negatives to get inside the cell, it will have synergistic activity. It's just that in vivo, that has never been replicated. So that's why when you talk about real life clinical practice, you'll never see vancomycin being used for gram negatives.
Yeah, and I think that there's the Elizabeth Kingia meningoseptica. That's one that as part of the testing we do vancom, but outside of that, I don't nothing else comes to mind. Okay. So as far as we definitely right in the lab we see vancomycin use, a lot with your strep use, with your staph enterococcus. So what type of organisms this antibiotic group treats?
Yeah, so I'm glad you brought that up because I've only been talking about vancomycin, and it's not because I'm a fanboy of vancomycin. It's because that is the most common one that you're going to come across. But I don't want to leave the others out in the glycopeptide family because Vanco was the first one. But then what we started doing was there was a drug that came out in the 80s. I think it was 1988 when it came in the market in Europe. It was called teicoplanin. Targocid, I think was the brand name of it. In the US, it is not available, but in Europe it is. And it was it was very much a naturally found glycopeptide. It's just that it's not commonly used anymore. But more recently, in 2009, we came across this semi-synthetic glycopeptide that was named telavancin. So that was introduced to us. It had very similar mechanism of action as vanco, but what it added was on top of the cell wall disruption, it also worked on the cell membrane stability. So the vancins, as we call it sometimes, telavancin, it added a little bit more potential with the gram positives on top of vancomycin. So sometimes, you have a staph species that vancomycin is not working effectively against. Telavancin sometimes holds its own because it's got this dual mechanism of action. And more recently, we've had the two new products out called dalbavancin and oretavancin. Similar to telavancin, they have a dual mechanism of action, but what makes these drugs unique is that they're actually long-acting antibiotics. Their half-life is usually 10 days, 7 to 10 days. So usually vancomycin and telavancin are once a day drug. Vancomycin can be twice a day depending on kinetics. But these drugs, these oretavancin and dalbavancin, are kind of cool where they're doing similar things as vancomycin does. However, you only have to give these drugs usually once a week. And sometimes if you're treating a 7-day course of an infection, it's a one and done, one dose and you're done because it's going to hang out for 7 to 10 days, which is sometimes, skin infections and things like that. That's how long we treat for. So vancomycin is still the most common one, the one that's most famous. But I would be doing disservice if I left some of these other semi-synthetic glycopeptides out because they're actually very, very, in the world of infectious disease clinical practice, they're actually very essential for us, especially now.
Nikunj, could you just to add to that, could you talk a little bit about the role of vanc for C. diff?
Oh yeah, so we didn't talk about that, but that is cool because vanco is unique in a way where it has anaerobic activity for a lot of the gram-positive organisms. But one of the formulations that comes in is oral. So usually when we talk about vanco, 95% of the time when we talk about vancomycin use, it's IV only. Oral vanco is unique in a way where it's not absorbed. It stays in the gut. So we don't ever use oral vanco for anything that is an infection outside of the gut. And one of the most common gut infections that we come across is C. diff infection, C. diff, Clostridioides difficile. Vancomycin is very active against. In fact, it's one of the drugs of choice. So what we usually do for treatment of C. diff that is associated diarrhea or colitis, what we usually do is we give oral vancomycin therapy. It is the only time you're going to see a non-IV formulation of vancomycin being given or oral formulation of vancomycin being given. And it is so effective against it that it's actually a first-line therapy. And it's one of the first-line therapies. So it's fair. It's a common practice. You see it on the hospital, inpatient, outpatient side, where a lot of the hospitals will have capsules, which it is available in. Some hospitals will even compound the medication. But C. diff associated diarrhea, oral vancomycin is going to be one of the options for sure.
Oh, that's great. Thank you. I think that's just something important to note because I think it's a little confusing when you're in the lab. You might be aware that vanc is primarily IV. And so then when you hear about it used for C. diff, I think people are like, are they getting like outpatient IV for vanc? What's happening there? So that's a really cool point to drive home. Thank you.
Yeah. And on the flip side, IV vancomycin will usually not treat C. diff associated diarrhea well. So it has to be, I'm glad you bring up that point of emphasis that it has to be oral formulation, which is unique to that.
Okay, and I just wanted to ask, because I kind of mentioned, right, so it has activity, we use it for staph, and then we also use it for strep, we use it for enterococcus, but it's also some other organisms, right, like some gram-positive bacilli. Can you talk more about that?
Yeah, so if you in general, if you talk about spectrum activity, you're like you mentioned, you're hitting your most common ones that are gram-positive aerobic cocci, like staph species, streptococci, enterococci. But it also has some of the other species like Corynebacterium, Listeria, Bacillus species, and then we talk about Clostridium species. It also treats some of the other oral anaerobic floras like Peptostreptococcus and Propionibacterium species as well. But again, if you're talking, intravenous use, or predominantly what is this being used for, it's going to be your bread and butter MRSA or MRSE or Staph epidermidis and Staph aureus. That's where you're going to see majority of its use, and it's primarily because we have other agents that could potentially target some of these other oral anaerobic oral flora anaerobes and other above the diaphragm anaerobes. The way I was taught how to remember if an anaerobe is likely to be gram positive or gram negative is that generically speaking, if an anaerobe is present above the diaphragm, it's going to be a gram positive, and if it's generically speaking, if it's below the diaphragm, it's going to be gram negative anaerobe. So when you're talking about these anaerobes that are above the diaphragm, you have other options, primarily beta lactams potentially targeted. But vancomycin, the way I think about it is everything gram positive. That's vancomycin essentially. That's how I tell my students that if you want to go to sleep and knowing that you covered your gram positives, give that patient vancomycin, and most likely you'll be covered. But the real utility is in MRSA, and then as well as Staph epidermidis, because that's where these are difficult to treat infections. They usually cause severe infections, high morbidity, high mortality. But we want to use an agent that we know for sure is going to work. That's why, like a lot of the patients who come through our ED, when they're critically ill and sepsis, severe sepsis, septic shock, first line therapy they'll get is vancomycin for that MRSA coverage that they will need. So I mean, essentially, that's where you in clinical practice, that's where you're going to see majority of its use. Enterococci is a unique one too, because enterococci, there's two main species, right? So faecalis and faecium. Faecalis is almost always sensitive when it comes to vancomycin. Faecium, I think about faecium as like facetious because it tends to be more resistant. So usually when you see a VRE, which is vancomycin resistant enterococci, that is usually a faecium species, and that's one of those things where you're looking at alternative options at that point, because vancomycin will serve no purpose at that point in a VRE setting. But luckily it's not as common as some of the other gram negative resistance are. So rarely we'll see it, but every now and then we'll have a patient who is a chronically admitted intra-abdominal manipulation, fluoroquinolone usage, cephalosporin usage, which is kind of putting them over the top with the VRE acquisition. So, but yeah, I mean, essentially you think of gram positives in general for the most part.
Excellent. And and for the lab, those of you that work in the lab are listening to this, as we talked about VRE, and also know that, and we're not going to go, talk about the genes and things like that, but you get two species which are Enterococcus gallinatum and Cassila which they have like a low level intrinsic resistance to vancomycin. And those, when we think about MICs and you're looking at a profile for a VRE, you see greater or equal than 32. And when it comes to this, you tend to see sometimes maybe like a 4, you might see an 8, and things like that. So just for the audience.
Yeah, one thing I can add, excellent point. And one thing I can add is, so, the common questions I get when it comes to MIC interpretation, when it comes to vancomycin is, so staph species, when we talk a little bit about mechanisms of resistance or how to interpret resistance, staph species, Staph aureus, for example, the CLSI cutoff would be 2 as a sensitive. Anything more than 4 is considered intermediate. That's your Visa, for example, vancomycin intermediate Staph aureus. But for enterococci, the cutoff is actually 4. However, when we talk about resistance or developing resistance, there is different ways that those two organisms express resistance. VRE, like you mentioned, almost always tends to be that if it is VRE remember the alanine and alanine that we talked about, what ends up happening in the setting of VRE is that alanine becomes alanine and lactate. One of the amino acids gets switched. So now vancomycin comes in and tries to bind to this alanine, and alanine is not present. They can't do anything. So it doesn't matter how much vanco you give, it will not bind and it will not work. And that's your classic resistance. With aureus, it's a little bit different because your MIC of 2 is considered sensitive, but then what ends up happening with Staph aureus is the cell wall gets thicker and thicker. So that is a common phenomenon called the MIC creep, which is where you have patient on vancomycin, their MIC is 2 with Staph aureus. Next thing you know, patient's failing therapy, and then you repeat sensitivities, and now your MIC becomes 4. And that's because your cell wall became thicker. Now your targets, you had 10 targets, for example, that you had to target with the amount of vancomycin you gave. All of a sudden, your targets doubled to 20, and now you were giving enough to cover 10 targets. So now you have to give enough to cover 20, which usually means that medication is becoming not a best option anymore. So yeah, resistance is very unique when it comes to this drug because beta-lactam, it's easy, right? It's beta-lactamase inhibitors where they inactivate the drug. That's what that's how the bacteria get smart. With Staph aureus and enterococci, 2 different ways of approaching this antibiotic.
And I was going to ask, before I ask the question, something for the audience, and keep in mind that when you're doing susceptibilities and when it comes, you have an Enterococcus faecalis or a faecium, and one of the things that when you see that resistant result, definitely make sure that you check for that purity plate that you're setting up in the lab, making sure, because especially when Enterococcus, the visas and the versas, compared to the VREs, right? VREs tend to be more common in the lab, but always check your purity plates, because a lot of times you can have a yeast there, you can have a gram-negative raw. So before you go reporting, I have a vancomycin resistant Enterococcus faecalis, make sure you go to those steps, right? You just want to be careful. I just want to always like to emphasize that with the text out there.
Luis, are you guys still doing any of the like kind of old school confirmatory methods? Like I would, I know I'm relatively young, but honestly, when I was back, when I was in the lab, when I started, we actually really didn't have any PCRs available or anything. We certainly didn't have MALDI. And so a lot of our confirmatory testing for things like VRE was actually really intense for the reasons we've already mentioned. So the species with intrinsic resistance versus a true VRE, right? We would do all sorts of things after we'd get the MIC to confirm that we were actually seeing a faecalis or a faecium, right? So we would do like look for, color of the colony might have a yellow tint if it's one of these intrinsic species. We had little biochemical vials that we would use and look for a color change from green to yellow. We would set an E-test to look for a more specific granular MIC. We would, look for, we had this whole algorithm, like you were saying, that's massively, high MIC versus one that's a little more kind of like indolent. So I'm sure things are quite different now. I don't know if you're still using those techniques, but it goes back to your point of really making sure you differentiate between the two, because there is a clinical interpretation there and difference in the way that's managed if you're talking about an intrinsic Enterococcus species. And those patient populations tend to look potentially a little bit different as well.
Yeah, and when it comes to that, we do have a message in our Vitek instrument that when we get one of these, like we got an animal Castelflavus, that it asks us to confirm the ID before we report it. When it comes to other things, I know like in the lab, if we get with like a staph and we have a vancomycin of 2, we recheck it by another method, and definitely in the case that we get one higher, we do a broth microdilution to check, make sure that confirm that result. So I always like to ask about intrinsic resistance. So when it comes to this group of antibiotics, is there any intrinsic resistance that we should know about?
So, I mean, I think we talked about gram negatives earlier, but that's the biggest group that, from not getting too much into the nitty-gritty details of things, but that is the biggest group that, usually you can label that as a quote unquote intrinsic resistance. You talked about some species of Enterococcus as well, but essentially the more clinically relevant would be the gram negatives, I would think, just because of the fact that it's a molecule that is going to have a penetration issues to the site of action where it needs to work. And unfortunately, with the outer layer, with the porin channels being the transport method, it's just not going to get to the site of action. And that's where you're going to draw a limitation when it comes to spectral activity.
Luis, can I add some weirdo ones for the laboratorians as well, just as like a something to be aware of. I don't know, again, since we've moved away from a lot of manual methods, I don't know how relevant this is for folks anymore. But we would always do, if we had a positive blood culture, we would plate the blood, we'd drop a P disc and a vancomycin disc so that the next day early on we would see if there was any sort of vancomycin resistance or strep pneumo for the zone around the P disc. And so it would be really helpful for us if we saw colony morphology that was really tiny and wimpy and gray, and the gram stain was positive and it was vanc resistance, we would look for something like leukonostoc or pediococcus. Those are some gram positives that are intrinsically resistant, if memory serves me correctly. I think also lactobacillus, you will see this as well. And Ursipelothrix, I think, are the four big ones. Again, we've got Maldi now. You may not even see, you know what I mean? You're like probably not putting that on your automated susceptibility test system. There's not breakpoints for a lot of these. Clinically, what it means may not really make a difference. But if you were still doing a manual method, or you're in a system where you're using a lot of manual methods and you happen to have a vancomycin disc dropped as like a pre-screen and it's a gram positive, just know there's a few weirdo ones where this is a great, actually a really easy identification tool paired with a gram stain, because they're kind of known for that. So just something to kind of keep in the back of your mind for old school micro techniques.
One thing I'll add when it comes to manual testing also. So one thing we used to do is, you touched on it earlier, is when you have an MIC of 2 with Staph aureus. So for background, vancomycin dosing, pharmacist in me coming out right now, usually pharmacists love to hate vancomycin because the dosing is based on a lot of pharmacokinetics. And where micro comes into the picture here is that one of the kinetics parameters that we follow is AUC over MIC. So AUC is how much vanco is in the system of a patient, and then MIC is what is the minimum amount of vanco that we will need to kill that bacteria. And if the MIC is considered to be greater than 1 for Staph aureus, you would have to essentially double your dosing of vancomycin concentration, which usually leads to side effects. So what we did, where I used to practice, was if you had a 2 MIC, like Vitec or Microscan was calling it a 2, then we would do an e-test to confirm, just because on the kinetic side, on the pharmacy side, it makes a big difference. And that also held true where you potentially led to failure in therapy with even a 1.5. So if our e-test called it a 1.5, we would deviate away from therapy to use something else, because otherwise you would be pushing the dose and now you're risking side effects.
Well, that's super interesting. I think we're going to talk a little bit about the levels and dosing and things a little bit further on, but I think that at least, was something I was always hearing from my clinical colleagues in the hospital, was checking levels and thinking about dosing and thinking about kidney injury and things like that with vanc. So I think it's a really important point. Luis, before I ask my next question, did you want to say anything else about intrinsic resistance?
No, but I think as you were just talking about the vancomycin and from the lab side, because normally when you are looking at a profile, let's say for like Staph aureus, right? So you typically, very classically, your vanco comes in at 0.5. That's a very classic MIC. And it just, as you were talking, it makes me think that sometimes when you get a 1, which is still a susceptible, and it gets released, we tend to get some requests saying, please, retest vancomycin by e-test. That's actually what it says on the note. So it's actually kind of good to put all those concepts together. So definitely thank you for that. But no, as of right now, I know I've been asking a lot of questions. So go ahead, Andrea.
Okay, now I think this is really great. I think we're learning a ton today. I love it. Okay, so Nikunj, you already talked about this a little bit, and I know you don't want anyone to think you're a huge vancomycin fanboy, so I won't tell them you're wearing your vancomycin t-shirt or about your I love vanc tattoo on your arm. So that'll be secret, stays safe with me.
Thank you.
Yeah. But I guess, you did already hit on this, but is there anything you want to add as to why a clinician might choose one glycopeptide over another? And I think vanc is always front of mind, but I love that you're talking about these other ones, because for most of us, I'd say 99% of us, vancomycin is the only one we're thinking about on the micro side. So why would someone choose something else?
Yeah, so within the glycopeptide family, vancomycin is obviously, like you mentioned, is going to be the workhorse. Vancomycin, like we talked about earlier a little bit, we touched on it with the Staph aureus, it has this MIC creep phenomena where what ends up happening on a clinical side of things is, like you were mentioning, that you had a Staph aureus with a vancomycin MIC of 1. Um, and we start vancomycin on those patients because they have an MRSA. Everything's going great because you were saying, hey, I have my MIC, my kinetics are lining up, everything's good, but patient's not getting better, and all of a sudden they have a breakthrough bacteremia or breakthrough infection where you had two sets of negative blood cultures. All of a sudden, they start spiking fevers, and now you have another set that you draw, which turns positive in a setting of bacteremia. And that is a relatively common phenomenon with when it comes to vancomycin, when it comes to those MICs that are borderline. So, like you were mentioning earlier, that you have a vancomycin MIC1 and we want a confirmatory test. That's probably one of the reasons why, because the clinical picture is not correlating with what the kinetics as well as what CLSI will tell you would be effective therapy at that point. So that is probably when you deviate away from vancomycin therapy more often than not. And these other vancin drugs that I talked about, telavancin, for example, they come in really handy. There's another drug that is not a glycopeptide, but it's a cyclic lipopeptide. It's daptomycin is a drug that commonly you probably get request for dropping an e-test for an MIC check. That becomes like an alternative agent also. It has very similar to Vanco, but it actually has activity against VRE as well. But when it comes to like alternative glycopeptide, telavancin is probably where you kind of search for as an option, because vancomycin, in clinically speaking, is not responding. Now, my whole life, I have never seen a VRSA, a vancomycin-resistant Staph aureus, and I would want to keep it that way. But H. visa is a thing now, where we're seeing it relatively more commonly than we did maybe a couple of decades ago when it was first found. So, you do have to have as much as we like to use Vanco, there are cases where patients are not clinically responding to therapy, even though everything else should tell you that they are. And that's when you search for these other options. And like I mentioned earlier, the vancins have dual mechanism of action. They're not just the dial cell wall agents. They also have the cell membrane activity. So, the cell wall thickening part is not as big of a deal for them, just because of the fact that you have dual mechanism that's working. So, transitioning to those kinds of things would be helpful. And then the newest concept that you're going to see more and more data published, and there's already plenty published in it in the last 10 years or so, is combination therapy with a glycopeptide. So what you're going to see is a beta-lactam plus a glycopeptide combination for Staph aureus especially. So what you're going to see is a vancomycin plus a cefazolin, or vancomycin plus a ceftaroline. And that is to target different targets on the cell wall. So the vancomycin is there for the dealanine, and then there's other action mechanism of action being done from the beta-lactam side. So you're punching different holes into that cell wall, which potentially makes it a better combination if your monotherapy is failing.
Oh, that's great.
And one other thing that we have talked in this episode is that sometimes, when it comes to some drugs in the group, like for example, a great example that always comes is, tetracycline and minocycline, and you get a request, and then if you look at the CLSI 100, so it says, okay, if it's tetracycline susceptible, you can add that, put that interpretation, consider minocycline susceptible. When it comes to vancomycin and this group of drugs, the glycopeptides, can we apply the susceptibility interpretation of one to another in the group?
Yeah, so the answer is yes and no. The reason why I say yes and no is because vancomycin generally is the only glycopeptide that you'll have available as part of your panel that gets tested for gram positives. As far as telavancin or dalbavancin or ridavancin, some of the other synthetic glycopeptides, most laboratories don't have the e-test testing in-house. But because the mechanism of action, it's not a beta-lactamase, like an enzyme that's inactivating the drug. Generally speaking, it is considered to be susceptible just because vancomycin is sensitive. Because the mechanism of action, there's an overlap. But on top of that, there's a dual mechanism of action. So it's thought to be sensitive even in a setting where vancomycin potentially is not sensitive. So usually, unless you have the capability of doing any testing, the general approach is going to be that if it's vancomycin sensitive, telavancin should be sensitive as well. Daptomycin is a unique drug, and we're not talking about that a lot today. It's not a glycopeptide, it's a cyclic lipopeptide, but it kind of goes hand in hand with vanco a lot. And daptomycin is another one that, usually outside of a pneumonia picture, you can assume that if vanco is sensitive, then dapto is going to be sensitive. But the enterococcus is the curveball sometimes, because enterococci, if it is vanco non-sensitive, meaning vanco-resistant enterococci, I would say that you probably are not safe to assume that any other peptide is also sensitive based on the data, or other glycopeptide is sensitive, where it would be prove it to me that it is and I will believe it kind of thing. Where Staph aureus, I would say if vanco is sensitive, sure, assume. If vanco is non-sensitive, you can make the argument that maybe the other glycopeptides are also sensitive. Enterococcus, caution is advised, because enterococci is very unique in the way it has the penicillin binding proteins, where only a handful of antibiotics target it. So VRE, for example, is where we almost always will drop an e-test for daptomycin and not assume that it is sensitive, or a telavancin and not assume that it's sensitive, because more often than not, it turns out that if it's vanco non-sensitive, those drugs are not sensitive either.
It's way more complex than I anticipated that answer would be. I think that's great.
Yeah, I'm sorry, but it's one of those things where it's one of those things where these drugs are such niche drugs, that they're not on the cards usually for any of the systems that you use. And vancomycin it's been around for so many years, has so many caveats now when we apply it on a clinical side.
No, it's a compliment, because I'm like, I think I rolled in here just thinking I knew what I needed to know about Vanc and the glycopeptides, and I think that is inaccurate. So I love when I'm learning. This next question is inspired by spooky season. It's spooky season. We're getting close to October 31st here. We got Halloween coming. So let's talk about breakpoints, because they're spooky for everybody. So are there any recent breakpoint changes we should know about? I know that this drug class is a lot less controversial, if you will, than others, but is there anything we need to know?
Yes, there are no MIC breakpoint updates from CLSI or FDA I would say in recent years that I would say that are practice changing. I think the one thing that we're going towards is this idea of sensitive dose dependent. And that happens a lot more with like the other MRSA drugs, and other enterococci drugs. So like daptomycin, I keep going back to it, but daptomycin is one where we made some updates, where in the past we used to call MIC of 2 to 4 with enterococci, sensitive, but now we're calling it sensitive dose dependent. I think there's an international working group of infectious disease specialists, and then a clinical and medical microbiologist. Basically, they reached a consensus that empirical MRSA infection should be chosen regardless of the suspected origin of infection strain. So essentially, hospital or community acquired, you're going to be leaning towards a vancomycin therapy at this point for MRSA coverage. But when it comes to MIC interpretation and things like that, if an elevated vancomycin MIC in a susceptible range is obtained during the testing, the only recommendation that is pretty strong now from all the experts is that we touched on this earlier, is a second method should be used to confirm the MIC. And that is multifactorial. Number one reason is the MIC creep phenomenon. But the other aspect is how we dose vancomycin, because, pharmacists will get so hung up on drawing levels for vancomycin. If you ever work in a lab, you will speak to pharmacists so much, and it will always be about, did you get that vanco level? Did you get that vanco level? And it's because we have such a narrow therapeutic window with this drug, where MICs play a big role, because your MIC goes up, your whole kinetics calculations change. So that's why the confirmatory testing is probably the biggest update in the last few years. And it's a relatively old concept at this point. But as far as the breakpoints, like we talked about earlier, Staph aureus 2 is your cutoff. Enterococci is where you kind of have a little bit of a leeway. But again, Staph aureus is where we worry about the potential creep phenomenon.
Well, that's great. I think, I mean, your answers are super comprehensive and really, really helpful. And so this last question I was going to ask you is about any comments you might have on how we might be testing, using this drug in the lab. I think we've covered that super extensively. So I might modify that question just a little bit to just ask you if you could back up just a little bit on the levels and just very briefly explain why levels are collected, what that means, how often they're collected. I know this is just, it always felt like from my perspective in the lab that this was kind of this point of contention. They weren't coming back fast enough. Like, why were they taking so long? We were setting them out. Can you just help folks understand, clinically what this means and why it's being done?
Yeah, so IDSA guidelines now recommend that if you're treating a confirmed MRSA infection, you should be doing this testing, this pharmacokinetic parameter called AUC, which is area under the curve, over MIC. And the whole idea behind that is that you want to make sure there's adequate amount of drug in the system systemically to treat the infection that you have. And this is specific to MRSA. So usually what we do is we will get most cases, 95% of the cases, what we will get is this thing called a trough, which is a measured amount from the blood and at the lowest level when the next dose is due, on what that is. So 30 minutes before the next dose is due. And what that will tell us is usually there is a therapeutic window of 10 to 20 milligrams per deciliter. That usually correlates with effectiveness as well as toxicity, where greater than 10 is what we usually want for efficacy and less than 20 is what we want for toxicity. So we want to make sure that we're staying within that range just because we don't want to cause harm to the patient, number one. And we also want to make sure we're not pushing for resistance by underdosing the patient. So that's why we're usually hung up on getting these levels so that way we can calculate these kinetic parameters. And with these levels, we can actually calculate AUC over MIC, which is specific for confirmed MRSA infections. So that's why we'll always be drawing troughs, and they're usually drawn as steady state, which is usually like day 2 or 3 of therapy, or like 4th or 5th dose. Or usually 4th dose is where we'll target a level. So that way we know that they've gotten at least few doses where we know that this is going to be a consistent level from now on. And I'll give you an example. Like where I worked, when it comes to medication errors, vancomycin was always in the top 5. And that's because we were not able to obtain levels, and the harm was caused with nephrotoxicity or whatnot. And that's what we try to prevent.
That is really informative. Thank you.
Yeah, no, definitely. Thank you. I have learned so much, as we said, and definitely, I always love, especially, we do all the testing and but just get to know what's happening outside of the lab and getting a better understanding. This has been way better than I thought it was going to be, because I have learned so much. So, thank you so much. And before we kind of close the episode, Andrea, you have anything else?
No, just a big thanks, Nikunj. This was awesome. You're a great teacher. You're probably going to definitely get invited back here for something. Luis and I are going to scheme on it. So hopefully you had fun because, I think you've been a great guest. Thanks so much.
Awesome. Yeah, no, thanks for the opportunity. This has been fun. I mean, I was telling Andrea that I always like to discuss pharmacy things with non-pharmacy folks, because I actually learn a lot back on the different perspective, like, what goes on in the micro lab. Like I have a generic idea, but then it's nice to know what actually, where these results and all these interpretations are coming from. It's kind of cool. It's nice to have this two-way street.
Definitely. Before anything else that you want to add for the audience, Nikunj, before we close?
The only thing I'll say is that, if you ask the clinicians, Vanco gets a bad rep because of the narrow therapeutic window I said earlier. But, it's still a very good drug. And I feel like if you talk to your ID providers or ID pharmacists, tell them to go easy on Vanco, right? Because a lot of people love to hate it. But I actually feel like it's one of those drugs that we need, and we should be nicer to it.
I love that. He's a fanboy, you guys.
So for the audience, definitely, I hope you enjoyed this episode as much as I have enjoyed it. And if you haven't checked out the previous episodes of the AMR series, after you listen to this one, go back and definitely check the catalog for some other great information about other antibiotics group. So once again, Nikunj, First of all, Andrea, it's always great talking to you. And Nikunj, thank you so much for taking the time to be in Let's Talk Micro.
Yeah, thank you for the opportunity. It's been a pleasure, and hopefully we can do this again.
Definitely. More than welcome. And that, my dear audience, it's the end of this episode. I am so happy to be back once again. Thank you so much for your support, for your understanding. I hope that you got to maybe listen to older episodes and enjoy some of the other content. But I do appreciate it, This past 4 weeks have been very rough, and it seems that I'm coming okay on the other end, and I'm gonna get my master's degree, so I'm feeling very accomplished. But I definitely needed some time to focus on that. Those of you that are going through school, you understand, so thank you so much. And of course, I hope that you enjoyed this episode. I hope you enjoy learning about glycopeptides. As always, I enjoy sharing this information with you. So please continue bringing that passion to what you do. It's so important. You do such great work. And hey, if you are in Pittsburgh from November 15th through the 17th of this year, attending the ASM Conference for Undergraduate Educators, AMSCU, on November 16th, I will be presenting a poster about using podcasts as an educational tool. So I hope you stop by, say hello, and get a sticker. Get a podcast sticker. So, of course, as always, stay motivated, stay safe, and of course, Nikunj,
Continue talking microbiology.
continue talking micro. Until the next time. Bye.